Okay, so we're gonna we like this whole like fireside chat thing, but we decided we would have bourbon instead of at this point in the day, or
It's too expensive now.
it's too expensive. Yeah, exactly. Well, there's some really great small batch ones. So we're usually at the time like this, in other meetings where I'm a speaker the later day, I say I'm standing in your way to a cocktail party, but that's not the case probably here today. I'm Alan Gilbert, and I work in GE Ventures specifically, and I'm really excited to finish off today with Anne and really talk about let's get real and practical, especially coming off of this this small group exercise, and really try to talk in detail. And Anne's going to give us some real details about what some communities are doing, building off the things that we've seen already today, and talk about marijuana and a few other things. I'm just going to start by giving you a little bit about so why is GE here? Why am I part of the roundtable? And why did I think this tax incentive day was really important? I've been in GE now for about 7 years, and I inherited a program where we really were thinking about the large healthcare costs our business was incurring as a private sector entity. Even though there's lots of bad news about GE in the news nowadays, I'm sure you hear. We still have over 300,000 employees in the world, and in the U.S., still about 150,000 plus employees and retirees, about 500,000 retirees in America. And about 10 years ago, we were spending, in the middle of the recession, still spending about $3 billion a year on healthcare costs in the States. And so we started in some of the communities for which we have a large population, places like Cincinnati, Ohio, where we build jet engines, and Erie, Pennsylvania, where we still build choo-choo trains, if you will, and back in the day, a GE Appliances, although that business has been sold, and then in Houston, Texas. I started programs in those large cities where we have, in many places, 10,000, active employees working in a ringed fence facility and building jet engines, or in Houston, where our oil and gas business has grown so large through mergers and acquisitions that we have about 22,000 employees just in Harris County, Texas alone, which is the Houston area. And we began to really build things that started just about thinking about our healthcare costs, but ultimately we looked at the broader population health issues, because I sat and immediately began to think we had to start addressing these larger issues, and had to convince my whole executives in the company that we needed to care about things like pollution in the community, or early childhood education, or these other larger social determinants of health. And then we began building broad cross-sector collaborations. I said in GE Ventures, and for a reason, I've actually began to believe that there is a huge business opportunity for companies to start working around these social determinants of health. My job, really, at the end of the day, since I report ultimately to shareholders, is to look for new business models. And I think we're talking about tax incentives today, which are really we're at the very beginning stages of this. Is really new stuff in population health. And really, I think population health as a business model is a very new area. There's not that much out there, but I believe that a healthcare company like GE needs to have business opportunity and business models that look like this. If we keep selling MRI machines in 10 years, we shouldn't still have our healthcare business. But if we had new emerging business models where we were tackling broader population health issues, we could really change the trajectory of health in the country. So that's kind of the reason I've been thinking about this. We have also started because we saw a gap in leadership and how to cross-sector collaborate in population health. And folks in this room like George Isham and David Kindig and others know some of this, and of course my partners at the round table. But we began a program to work in 9 communities across the country that we recruited to actually try to train and teach them through a pretty rigorous curriculum how to cross-sector collaborate on population health improvement. And it's really interesting, because what I really saw in that was that you see all these programs like my program, right? I've been funding with resources all these cities, all these new cities, and we see RWJs here, others around, and I think this issue of stable resource and stable sustainability in a community is real. Like when my program ends, which will come up here in the next month, I've given each of these 9 communities, $25,000, but also will provide $250,000 to one or a couple of these communities that have made the most progress. And there's the Build Coalition that's out there, there's others. But what I have seen and run across in the communities that we have a footprint, and in these new communities which we're really testing leadership capacity building, is that once these programs go away, many times the entire effort goes away, or it falls. And this is not something new that you've seen, that you know more than I do how this happens. And so I feel like this is a real gap, and this topic today around tax incentives can really make a difference in trying to see these. You know, some of the programs that we had in Pasadena, Texas, and in Toledo, Ohio, were picking up where prior programs had left off. So we were filling a gap in resource and money that they needed to keep their programs going. And I hate to see those kind of things in, so I think it's really important. And you know, it's been here today already, so I mean, I'll just turn it over to you to talk more about some of the practical programs and tax strategies you've seen others do in communities, and then we'll just open it up for discussion. We're the last one, so feel free to, I'm always saying people to interrupt us and ask us questions as we go, but take it away.
Thank you, Alan. Well, I have to say, I think Trust for America's It's on. Great. Okay. Starting again. Thank you. I think Trust for America's Health comes to this discussion with a similar concern about the sustainability for resources to do this type of cross-sector work. Since 2012, we've been convening thought leaders to think about issues in population health, and specifically around sustainability. We've been having those conversations since all the way back to 2013. And so I guess I just wanted to start out by reminding us that this morning Bobby showed that schematic, which has a lot of different sources of financing for population health. And I look at tax policy as one of those areas of opportunity. It manifests itself differently. It showed itself several times on that schematic, but I think the aha for TIFA has really been that it's about diversification. Just like any other business, population health initiatives have to braid together various different funding streams, both operating and capital, to survive over the long haul. And the work that we've been doing has really been thinking deeply about what does that take? What's the infrastructure that's required to braid those different funding streams? And we've developed this model called the Healthy Communities Funding Hub. But I'm not going to talk about that today. I'm going to talk about some examples, like Alan said, of where I have seen tax policy contributing to what I think of as population health, and I look forward to hearing if you all agree. So I first wanted to point out, I think we haven't talked a lot today about what are we trying to fund. So I think of it in three different categories. We have talked about the social determinants of health. We've talked about EITC and LIHTC, for example. But we've also talked about other evidence-based policies and interventions. Stacy raised some in particular in her presentation, and that looks at both primary prevention, preventing chronic disease in the first place, community-level prevention, and policy systems and environmental change. And that's where we see a lot of the gap in the marketplace. Then there's a third category. And that's the infrastructure to do the collaboration, exactly what Alan just talked about. And that takes resources too. So when I think about tax incentives for population health, I'm thinking about all those three areas. Okay. So, all right, I admitted earlier I am not an expert in tax policy, so I really needed to kind of simplify this down in my own mind to two questions. Who are we giving an incentive to, corporation or individual, and what type of an incentive it is? And I tried to use the tax typology, and I kind of did. I've got taxes and tax expenditures, but I couldn't help myself. I had to add a category. That's the assessments, or generally known as provider assessments or provider taxes. So I'm going to give an example in each of these boxes. So you're going to see this slide a lot. If you want, you can use it as a chance to stand up and get some physical activity. You're going to see it a lot. So let's see if we can get it to click. Well, the first one, I filled in a couple of boxes that I'm not going to talk about because I feel like either the folks in the room and out there watching kind of know about them or we've already touched on them. So first of all is community benefit, the nonprofit hospital's obligations, right, in lieu of paying income taxes. So I'm not going to talk about that because I think we all know a lot about community benefit, but it is a way of incentivizing corporations, right, and specifically hospitals, to invest upstream, particularly since those regulations have now been adjusted to recognize that broader view of health. We've also talked about sugar-sweetened beverage taxes and tobacco taxes, so I'm not going to talk about those two. But I do have some other things in those categories. So first of all, first one example is Sojourner Family Peace Center. This is a family justice model that exists in Milwaukee, Wisconsin, and it leveraged a bunch of different tax policies to create this family justice center, including new market tax credits, community benefit, state building commission funds, might consider a tax policy, and they also got hospital loans as part of their community benefit. So this, again, is a family justice model. That's a national model. This is not a federally funded family justice model, but it does operate on that model. It is, in fact, the largest array of services under one roof to combat domestic violence and get to the roots of trauma. So it combines a 56-bed shelter with law enforcement, medical services, behavioral services, and like 19 different programs operated by 10 different community providers. And the financing story is really interesting and includes a lot of tax policy. So I want to make sure I don't miss out on it. So this was a partnership, first of all, between what already existed, the Domestic Violence Agency, Sojourner House, and Children's Hospital of Wisconsin, which is the child welfare provider in the state of Wisconsin. So they had some skin in the game in terms of looking again at the roots of violence, both as it impacts domestic violence and child welfare. So Children's and Sojourner together applied for money from the state of Wisconsin Building Commission, okay, to the tune of more than $10 million. In order to get that, Children's Hospital had to, first of all, they had to apply. To apply for the Building Commission funds, Sojourner House wasn't even eligible. So the hospital came in to help them apply. They also loaned Sojourner $10 million, which was basically used as the match for new market tax credits. So when they drew down the new market tax credit funds from the state, the Children's Hospital got its money back in terms of that $10 million. But again, the Domestic Violence Agency didn't have the money in the bank to serve as the match for the new market tax credits. So they got $4.4 million in new market tax credits. And in addition, the hospital donated $3.8 million in community benefit funds. So basically, you add all this up, and they now have a debt-free $27 million facility. There was also $8 million in philanthropy raised, so it wasn't just the new market tax credits, the community benefit. There was this philanthropy and the state commission matching fund, but I mean, that's a pretty amazing deal that they now have a debt-free building. In return for the community benefit contribution of the Children's Hospital, the hospital gets rent free for life in this building. But in addition, they are also paying some of the operating costs of some of the smaller agencies that are operating out of the building that are serving the needs of those women and family. So an incredible, I think, example of combining a bunch of different tax policies to meet a really important need in the community. This thing is funny, isn't it? Okay. All right, next one. I'm not going to talk much about this one either because Stacy already did, and her colleagues. This is the state charitable giving tax credits. I think the one that I thought was really interesting in Arizona, where they basically give taxpayers a list of the anti-poverty organizations that qualify for this. You can also contribute to schools and get that tax credit. So that's aimed, of course, at individuals. And all of those are examples of tax expenditures, not taxes, right? But let's talk about a couple of taxes. So I think a really cool example of a sin tax is what they've been doing in marijuana in Colorado around the marijuana tax. So Colorado has major issues in terms of the behavioral health needs of their students. Some of you may be aware, particularly in terms of suicide. It's just very sad. That state is really in a crisis. So they've long recognized the need to invest in young kids in terms of behavioral health services so they don't get to, that point of suicide. And they also have some problems with substance use. So they recognized this, and they knew that delivering those behavioral health services in schools was a really effective, evidence-based way to address those issues, particularly if combined in a population health approach that really uses multi-tiered systems of support to make sure you have a positive school climate, et cetera, positive disciplinary practices. So not just about behavioral health or substance use services in the schools, but also making those schools a culture and climate friendly for kids and the other people in the building. So what they've been doing with the funding from their marijuana tax is providing this type of support in schools. Specifically, it helps schools hire psychologists, social workers, counselors, and nurses that provide these behavioral health and substance use services, literally funds those FTEs, their professional development and training, as well as other resources, again, to round out the model beyond services alone. And it's been so successful in terms of the increasing volume of behavioral health services delivered in schools that after the first year, when they got a little over 2 million, they ended up getting 12 million. And so they've gone from 66 schools to, I forget how many schools they have this year, but they have 54 grantees, and they had 22 grantees previously. They've really been able to significantly expand these services, and they've been able to go into elementary schools. The first year they were just in middle and high schools. And what's more impressive to me, to my point earlier, is the way they're braiding these dollars with so many other sources of funding. I mean, okay, Medicaid, of course, is paying for a lot of those services in schools where the kids are Medicaid eligible. They also have this Project Aware grant from SAMHSA that has provided that foundation for the multi-tiered system of support network that they are putting together. They've used state personnel development grant funds. Those are funds that come from the Department of Education originally. And then they have some state bullying prevention and education grants as well. And so all of these braid together to get even more personnel, as well as all the services and supports those personnel need to deliver services and work on school climate and culture. Yeah. Yeah.
I think it's a lot of. I think it's a lot of sale of pot.
Well, no, but that money had to be allocated, and they were able to make the case because when they put those providers in the schools, the kids were accessing the services like crazy. A lot of states then try to pull back and say, whoa, we didn't mean to give that many new Medicaid services, right? But no, instead they said, this is exactly what we need to be doing, is getting these kids, intervening early with these kids. And so they added funding and they went earlier to the elementary school. So they really got it.
Many of the funds were raised directly to that intervention.
Yeah, they upped the amount of the tax essentially. But this is, again, that's only a small piece of the pie because they're braiding together all these other funding streams. And they probably sold more pot too. There was more money in the fund, and so they had to spend it somehow.
Ann, I don't want to stop you there, but
Yeah.
I do want to make sure we have time for questions.
Yeah.
But I know you want to have another example too, but
Yeah.
I'm really interested in this concept of braided together and how difficult that really is, and you're seeing this in the country, because I know when in the places that we've worked, so many of these organizations are almost in silos in the community.
Mm-hmm.
I mean, I've seen instances where you walk into a community and public health doesn't even know the people they need to be talking with in community health, and if you think they know the criminal justice system, boy, that's really wrong. So this idea of braiding together these resources means they have to know how to talk with one another.
Yeah.
Speak a little bit about that, like if you could, like how hard it is in your examples. Has it been easy for them?
I think what TIFA has learned over the years is it's difficult to do primarily at the community level because you don't have the appropriate infrastructure, right? You might be running your multi-sector coalition on either no staff or maybe like half a person, right? That brings people together for the meetings, but you don't often have the financial management systems, the type of governance you would need, or the data capabilities really to do that type of braiding. But I've also really learned that it's really hard to do at the state level, which is a little bit more surprising, but nonetheless true, that it's very hard. So in Colorado, they're working between the Department of Education, Department of Healthcare Services, Public Health. So they're really working across multiple state agencies to try to bring all these funding streams together. So it's hard. It requires infrastructure. It doesn't just happen without any personnel to do it.
So is that kind of a message to the today, which is that this new source of revenue could be dedicated to infrastructure, right? It's one of your messages.
That's my next example. Perfect. I swear I didn't have him tee that up. So this is the Florida Children's Services Council. Yes. Yeah.
Back to the braided funding, so the tax dollars that they were able to secure, were they restricted in terms of what services were provided, or did that allow them a band in which they could provide whatever's needed in the scope of that work? The reason why I asked that is I looked at some of the other funding sources, like the state development grant, which could be used for training, but may not be able to be used for treatment or assessment.
Yeah, such a good point.
But with the tax dollars, did they negotiate a band of opportunity in which to use those funds?
Yeah, it was allow them to hire the providers that could deliver those behavioral health services. And as you saw, it was a range of different types of providers. So, Colorado, particularly in their education districts, it's all about local control. So they didn't want to impose any model. They just said, with these funds, you can deliver behavioral health services, to your students. And then they chose how they did that through a school social worker or a psychologist, or based on, what their local needs and preferences were.
Would they have been able to use that money?
No, I don't think so. It was to hire FTEs. Yes, and do training.
And did they negotiate that up front?
I don't know. That's a good question.
But I do like the way you're heading, which is in the future designing tax policies, you can actually fill a gap, right? Because we know that if you go for housing dollars, you can only do it for this. And if you go for public health dollars, you can only do this one narrow. This is one of the public policy barriers, frankly, in trying to resource population health improvement overall. Like, we need to be able to have some of this movement between them, but if you're designing a new tax strategy, you could literally look across all of these and fill those gaps by make sure that your tax resource is able to fill these gaps, right? So that's a very good point.
Yeah, absolutely. So again, to the point about infrastructure that you were raising, I think the Children's Services Councils are such a good example of that. And these go way back, to after the war, when they really looked at the need to have these kind of child welfare taxing districts. So, it was put forward in one local county. It was eventually passed at the state level. And this money funds that infrastructure that is needed to make sure that children and families are healthy. So basically, there's two types. There's one type where a property tax is assessed specifically to fund these organizations. And there's another type where a portion of the property tax revenue is put into a budget line, just like you would in a regular budget allocation system to fund these. So some literally have their taxing authorities. The county residents first have to, vote on this to happen, and then they vote on either model. So these operate throughout Florida. And they fund all kinds of things, two-generation approaches, nurse-family partnership, early learning, after-school programs, summer programs, juvenile justice. I mean, there's a list so long because they're funding whatever is needed for children and families in that specific county. They're all county-based. And the the cost, as you can see, is relatively low at $25 to $80 per taxpayer. That's not a whole lot. And what's really interesting is these are the organizations that can then braid all those funding streams together. They braid together 211 money, Kids Care money, Healthy Start Coalition money, Healthy Families money, school readiness money, you name it. They are an efficient way of operating. They bring these dollars into these children's services councils, and then they re-grant it out to the nonprofits that are doing the work on the ground. And it's the property tax dollars that are paying for this infrastructure. Girthar. I think they are county appointed, but it may differ since each county votes on their own structure. I don't think there's a specific structure statewide, but I'm not totally sure of that answer, but they definitely have multi-sector leadership from the community representing all these different sectors in child and family services. Like a school board, I guess, in a way, but I don't think they're like elected like a school board would be. So I think I mentioned, but I just want to kind of detail out kind of what I think, and this is kind of a concept that we've had around a Healthy Communities Funding Hub, the types of things that need to be done as part of that infrastructure. Administering the funds, right, so they're accountable and transparent to the taxpayers in their county. They're collecting information and data across all those programs, monitoring performance, leading the local strategic planning, like putting the whole big plan together about what is needed, and being an advocate to the extent they can use their funds to do so, providing that coordination and oversight for the county. So that's a really great example, not unlike what we're talking about with the Wellness Trust, right? Okay. Switching now to my made-up category of assessments. And some person who's a tax expert could tell me if that fits into taxes or tax expenditures, or it's just like taxes by another name, right? Assessments. So I wanted to give the example of the Massachusetts Determination of Need process. This is when you apply for capital expenditures. So you're building a building, or you're, buying an MRI from GE. And so what's the point of determination of need or certificate of need processes in states that still have them? A lot of states have gotten rid of them. It's to make sure that, there's not a lot of price inflation because there's an MRI on every corner like Starbucks, right? That there's appropriate access, but at a cost to the taxpayer that makes sense. So it's restricting some capital expenditures and do in a concept of local planning. And Massachusetts requires everybody to put in, as a part of their application for whatever capital project it is, one of these community-based health initiatives. And I thought it was really interesting that the language is very specific, that these are to address the social determinants of health, as well as align with goals from their state health improvement plan. So like some of their current goals are, let's see, I don't have them all here, but it was around like substance use, diabetes, obesity, et cetera. Mental illness, chronic disease with a focus on cancer, heart disease, and diabetes. So a portion of the hospital contributions, and specifically in regards to determination of need, also fund kind of a statewide community-based health initiative that is to help provide the evidence to the local communities, give them the tools for the interventions. So that 5%, that can add up to a lot. And what's interesting about this one is it's meant to work in conjunction with the state's waiver, which is the next example I'm going to talk about, waiver matches. So this is a little out of the box. Oops, I might have gone too far ahead. But I think most of us are probably familiar with Medicaid 1115 demonstration waivers, and most recently the delivery system reform incentive payments, which basically restructure payments to safety net providers in a pay-per-performance type of way. And so it's surprising to me to find out that the way the non-federal share, which is required for Medicaid generally, right, but it's also required for these waivers, that the non-federal share is being financed through taxes. So like in Oregon, they they assess a specific provider tax to come up with that state share to match for the 1115 DSRIP waiver. And these are big, right? These are multi-billion-dollar waivers. These are very large. And in many, many states, they use what are called intergovernmental transfers, which is like, okay, from your time on the Hill, you might be like, oh no, not IGTs. But these are legal. These are transfers among different public agencies. And so essentially they are taxes as well. They were what would be local taxes. They're sent up to the county or the state to be the match for the waiver. And states are asking hospitals, public hospitals, state university hospitals to do some of these intergovernmental transfers on a voluntary basis, right, as a match to the waiver. And why would they want to do that? Well, the waiver's in their best interest, right? This is even done in Arizona, they used these techniques to finance their Medicaid expansion. And to double down on that, the hospitals got to count the money that they were assessed as part of their community benefit. So they used a provider assessment that also counted towards the hospital community's benefit, and they used as a match when they were expanding Medicaid in Arizona. These are pretty tricky. Okay, I think we're on our last one. Yes, Massachusetts Wellness Trust. So, okay, a lot of people probably would have thought I would start with this one. This is like the best known, right? But instead, no, I'm ending with this one. So the Massachusetts Prevention and Wellness Trust, I think most of us know that was a one-time assessment on providers, in this case hospitals and insurers, large hospitals and large insurers. That passed in 2012 and raised $60 million over 4 years. Oops, sorry, I do have this on a slide for you, to support prevention and health promotion grants. Those were for local community initiatives. Again, there were some state set priorities around that. For example, they fundable activities include enhancing community clinical relationships, addressing community members' barriers to optimal health, identifying health-related community resources, tracking referrals to community resources, and using quality improvement to strengthen community clinical processes and linkages. And they also, like the determination of need process, so now we've got 3 of these mechanisms in Massachusetts, right? They use the DSRIP match, they use the Wellness Trust, and they use the determination of need. So Massachusetts is in a lot of these examples. But they also set priorities at the state level according to their state health improvement plan of tobacco use, childhood asthma, hypertension, and elder falls prevention. It had some optional categories of obesity, diabetes, oral health, and substance use. So those are a lot of examples. I guess I chose, first of all, I'm not a tax expert, so I chose to focus on examples. But second of all, because to me, it's a hopeful way to look at this, right? These already exist out there, so they do provide ideas for what can be looked at in other localities or states, because they do exist. Some of them have existed, like the Children's Services Councils in Florida, you know, for a long time. So there's some evidence about why the public's supporting it and why it works. I think it also shows a good representation of states in terms of their political leanings, to say that, you know, this is not a partisan issue, which I know is how Bobby started the day. And I recognize that TIFA does a lot of federal advocacy and policy, and we did try to float some ideas for tax credit with the bill that most recently passed the House and Senate, is in conference, and there wasn't a lot of appetite for a tax credit. We gave it a try at least. So maybe there isn't an opportunity right now in the federal level, since tax policies already happened or are happening, but I do think there's a lot of opportunity on the local and the state level. So just a couple conclusions. Oops, which I blew by. You know, in all these, it seems like the business case really had to be designed for the audience, who perhaps the audience is those losers that Pete referred to, but we could talk about that. It's a lot about leveraging new opportunities. So, I mean, I think the marijuana tax is a place to look anytime there's going to be a new tax, trying to get your foot in the door, being at the table instead of being on the menu, right? thinking about one time, like those provider assessments, but also ongoing taxes. So I think ideally we look at ongoing resources, right? But sometimes there is a one-time opportunity. And bottom line, to me, it all comes down to building that political will.
Great. Well, I know we want to do a round of questions. I think we have a few minutes, but thank you so much. I just want to point out before you do questions is I think Pete started the day talking about how you made this comment in about not much political will at the federal level, but Pete started the day out talking about how most of these ideas start, even you and I, old dogs from Washington and D.C., so many ideas that end up in the federal arena have started at the local and state levels to start with. And I can go through, history. And he said start at this level and sort of build the case for these. And I think what you've really shown us today and what really a lot of this conversation today has really shown, I don't want to steal George's summary up at the end of the day, but I think it really has shown that there are some really creative ideas out there, not just in the, and you've shown us that it's not just in these traditional tax ways by adding your third column. I like your third column. So with that, I'll open it up for questions and see if anybody has any questions they want to ask before we wrap up. Yes.
You described some really interesting the braiding examples, but how did they, if you could pick one of them and give us a story of how, almost like a Pete story, like how did it come to pass? How did it get done? Because I think that we've got a lot of really interesting ideas in front of us right now, and so the question I have in my mind is, how do we do this? How do we get to this? How do we begin to think about opportunities where we can influence policy?
Gosh, that's such a great question, and I don't know that I have a good answer, but that I think when bubbling up locally or even at the state level, when there's been a burning issue is when you're more likely to get movement, right? So the opioid epidemic is a good example right now. What if in Scott County, Indiana, they talked about trying to create some type of tax to fund needle exchange? Because hepatitis C is getting to be out of control, HIV is starting to be out of control, right? So if you can work from what is clearly an issue that is impacting the community broadly, especially in terms of the health outcomes and the costs, it seems like you could get more momentum to change something. Or a new tax is going into effect, or a tax is up for some kind of renewals, and you have a political opportunity. Then combining those two things, the awareness of whatever burning bridge and the new opportunity, is the way you can match them together. But maybe there's people were sharing, Girthar, you were sharing about Philadelphia, maybe we heard about the Berkeley tax, how that got done, so maybe people have war stories they can share of how they advocated.
The only thing I would add is the braiding reminds me of something that I heard Javier say earlier today, which was bring the whole cross sector of the community together from the beginning. And you certainly can't, your examples show that, ideas come when you say, okay, I know I have these 5 resource funding streams now, but it's not enough, and so how do I get others? If you don't have the right people at the table, I've seen that in all the communities that I've been working in that I'm part of, is you have to have them all bought in from the beginning. And so that's a way of really, and if you do, then you can really move quickly to take advantage of opportunities. As we all know, some of these things sort of almost move really quickly. Like I have to have every insurer plus everybody in the community from the health delivery system plus the broader social determinants to work on this new, CMMI innovative thing, and I got to turn it in by December 20th. Yeah. If you're already collaborating, that's pretty easy. If you're not, hard.
Might be a champion is also a big key factor, right? So I'm thinking of Rochester, New York. I believe they did a provider assessment to fund their initiative around cardiovascular health, and that it was Danny Wegmans from Wegmans Grocery Store that was like, okay, we got to do something about cardiovascular health, and as a major business and community leader there, was able to marshal the political will for an assessment, which is a lot of political will, right? So the championship can't be underestimated. So isn't that what we're doing today? We're growing champions.
Any other questions? End of the day. Thank you very much.